Megamind.
Hi everybody, my name is Bernardo Correa. I'm from Portugal and I share with you the benefits of a responsible tooth extraction in our daily practice. On November the 8th, 2020, Frances, a 64-year-old healthy Caucasian female, showed up in our clinic complaining about her tooth number 7's poor aesthetics and repeated crown fractures. A permanent mild discomfort on tooth number 7 apical area was also referred, possibly due to the apical granuloma revealed at the CBCT scan. Aware of the post-extraction tissue collapse's negative effect, especially at the anterior aesthetic zone, we always try to avoid tooth extraction whenever it's possible. So, in an attempt to save tooth number 7, an endodontic retreatment was performed. Yet, despite the apical granuloma's significant improvement after 4 months, the patient still complained about some occasional mild pain and fractured its resin composite restoration again. So to predictably solve this patient's problem, a dental implant placement was proposed, since the patient was not compliant with the idea of going through an orthodontic treatment to solve her perfunctional forces that led to number 7's chronic fractures. Therefore, any aesthetic ceramic treatment would not be, in this case, a predictable solution. So since we were dealing with the anterior aesthetic zone, for this case our treatment objectives were trying to provide immediate aesthetics, placing an immediate post-extraction implant, and if possible, do immediate load, try to provide a screw-retained crown, since it could be easily removed in case of need, and of course try to provide high aesthetics and long-lasting results. From the soft tissues point of view, this patient presented a favorable thick biotype, but the CBCT scan showed a thin buccal bundle bone prone to easily resorb after tooth extraction. Since we were dealing with a Gluckman's classification type 1B with scarce bone availability, to make sure that the implant's angulation was compatible with a screw-retained prosthesis, a R2-gate surgical guide was made. However, committing to that implant position would compromise obtaining an optimal primary stability, as well as providing a predictable immediate aesthetics. Even though, since home confinement and mask utilization were mandatory during that COVID pandemic period, the patient agreed with the planning, as an immediate aesthetic was no longer a major requisite for her. But if we don't address tooth extraction on a responsible way, we might fail to reach our treatment objectives within the first months due to bone remodeling and tissue collapse. Because the bundle bone post-extraction resorption is a biological phenomenon that can't be stopped by any procedure unless you leave the root in place. And this is the reason why, in order to prevent tissue collapse, our first option is always to try to do root membrane. So on March the 4th, 2021, we performed a simplified variation of the root membrane standard preparation protocol, the Moon preparation protocol. First, we used the initial Shaper 1 drill from the Megagen's root membrane kit to totally remove the composite restoration without touching or harming the neighbor teeth. Then the root canal filling was fully removed with a Gates-Glidden burr, revealing some root canal infected dentin that was eliminated by enlarging the coronal root canal aspect with the initial Shaper 1 drill, in order to obtain an extra and extended root canal disinfection. A 2% chlorhexidine solution rinse was done for 3 minutes prior to the remaining root canal length enlargement with the initial Shaper 2 drill to prevent socket's root canal bacteria contamination when slightly surpassing the root apex. With a gentle mesiodistal motion, the root was separated in 2 fragments, one buccal and the other palatal, making sure that there was enough clearance in between them to allow the luxation of the further luxation of the palatal fragment without compromising the buccal stability of the buccal fragment. At the root membrane's Moon preparation protocol, the main role is played by the Megagen's root membrane kit's 3 mm round drill. In order to understand this preparation protocol, we need to know 2 measurements. The first one, or the first measurement, is the round drill's depth first laser mark, which is 5 millimeters. The second measurement is the round drill's cutting equator distance to its 5 millimeters depth laser mark, which is 3.5 millimeters. The 3 millimeter round drill's cutting equator is an imaginary line that split its diamond sphere into 2 1.5 twin or equal halves. So its distance to the 5 millimeters depth laser mark is calculated subtracting 1.5 millimeters from 5 millimeters. The goal of this protocol is to use the round drill's cutting equator to thin down the inner surface of the buccal root fragment into a cut line. This allows us to vertically reduce the buccal root fragment to the bone level without damaging the free gingival margin, which is a mandatory detail, especially in thin periodontal biotype cases. The 5 mm laser mark was used as a depth limit control, having the free gingival margin as a reference plan. So we should always stay slightly above it but never deeper than it to make sure the root fragment is vertically reduced to the bone level and never under it. Performing a gentle mesiodistal motion along the root's buccal contour will allow the buccal root fragment's vertical axis to easily detach in one piece without damaging the free gingival margin. The next step was to use the Megagen root membrane kit's final shaper drill to eliminate the sharp edges generated on top of the buccal root fragment's coronal aspect. These are called the widow peaks. These widow peaks are frequently responsible for the most common root membrane complication, the intra and extracellular root fragment exposure. The final shaper drill has a 3 mm depth laser mark that was also used as a reference to reduce the widow peaks to the bone level. Finally, using a thin periosteum elevator, the palatal root fragment was extracted without compromising the buccal fragment stability, since enough clearance between the 2 fragments was provided, which in this case was enough to also provide an adequate root fragment thickness, which should be from 1 to 1.5 millimeters. However, on wider roots, additional final thinning might be necessary, and it should be performed with the initial shaper number 2 drill. As referred before, to make sure we could obtain an accurate implant position that provided a screw-retained prosthesis, a R2 gate surgical guide was requested to prepare the implant site with the R2 gate surgical kit. and to fully guide the implant to its ideal final position. To achieve an optimal mucosal barrier, a transepithelial abutment was placed, even though there was not enough primary stability to perform immediate load. And since the buccal bundle bone was compromised by the implant placement, a minimal invasive ridge augmentation was done to prevent for any possible future complications with the root fragment. As we totally rely on the AnyRidge implant's osseointegration ability, on April 22, 2021, a digital design provisional was placed to immediately start shaping the emergence profile. And 2 months after surgery, soft tissues were ready to be cloned by the lab technician to produce the definitive ceramic crown, showing a perfect thickness around the transepithelial abutment that was never touched again from the surgery day on. So the abutment is now part of the implant and no longer part of the prosthesis. 5 months later, the definitive crown was delivered with a near perfect pink aesthetic score that got even better almost 14 months post-op. At the CBCT scan, we could observe a succeeded minimal invasive ridge augmentation and a stable buccal root fragment. So we can conclude that the root membrane technique can be a very reliable option when tissue collapse prevention and high aesthetic results are required. The scientific literature support is increasing every year and shows us that we can achieve less bone loss and a better pink aesthetic score when compared to the conventional implant placement protocol. With the root membrane technique, as time goes by, instead of assisting to the usual peri-implant soft tissue shrinkage, we can observe tissue ingrowth without any connective tissue grafting being done, allowing our dental implants to truly mime the natural neighboring teeth, or in this particular case, to even look better than natural teeth. Thank you very much for watching and for the chance of participating on this MegaMine Clinical Case International Competition. I'm Bernardo Correa from Portugal.
MegaMind.